Our speaker for this evening is Dr. Margot Davis. Dr. Davis is a cardiologist at both Vancouver General Hospital and St. Paul's Hospital. She is a clinical assistant professor at the University of British Columbia and director of the UBC Cardio-Oncology program. Dr. Davis obtained her Bachelor's of Science in Physiology at McGill University before attending medical school at UBC. She stayed at UBC for her internal medicine residency and cardiology fellowship. She then went on to complete fellowships in advanced heart failure and transplant cardiology and cardio-oncology and cardiac amyloidosis at Stanford University School of Medicine. Her research interests are focused on the prevention, diagnosis, and management of heart disease related to cancer therapy and the epidemiology of heart disease in cancer survivors. Additionally, Dr. Davis has interest in cardiac amyloidosis and advanced heart failure. Notwithstanding her very busy schedule, she is a candidate for a Master's of Science in Clinical Epidemiology at the Harvard School of Public Health. Without further ado, please join me in welcoming Dr. Margot Davis.
Well, thank you so much for having me today. It's a real pleasure to be here. As you've heard, I am a cardio-oncologist, which is sort of a new term, but what it basically means is I'm a cardiologist with an interest in cancer, and specifically I define my job as preventing and treating heart disease in cancer patients and cancer survivors. So today I've been asked to talk to you about heart health after prostate cancer diagnosis. So I put together a little outline. I'm going to talk to you first about what is heart disease, and then I'm going to touch on the connection between cancer and heart disease. What do these two things have together, and why are you here today? Then we'll talk a little bit about how you can reduce your risk of heart disease after a prostate cancer diagnosis. And finally, I'll let you know what the Cardio-Oncology Clinic is here and what we do. So what is heart disease? Well, there are actually many different types of heart disease, but the most common thing that people are referring to when they talk about heart disease is probably what the medical term would be coronary artery disease. Coronary artery disease means blockages of the coronary arteries. The coronary arteries are those blood vessels that bring blood and oxygen to the heart muscle. And coronary artery disease is caused by atherosclerosis, a disease in which plaque builds up in the arteries, limiting the flow of blood. So what you can see here is this is an artery, which is basically just a pipe that's designed to bring blood from point A to point B. And so normally blood's able to flow freely through a pipe like this. And with atherosclerosis, you get these plaques, which are basically just junk, cholesterol and fat and gross stuff that builds up in the walls of the arteries, limiting the cross-sectional area of the artery and limiting flow through the artery. So coronary artery disease is when atherosclerosis affects the blood flow in coronary arteries, and this can result in either angina or a heart attack. So what you can see here is you can see that this is a coronary artery that brings blood down to all the parts of the heart muscle. Here is a close-up of it. When you get junk building up here, if there's still a little bit of flow past here, you might experience angina, which is chest pain with exertion, when the heart needs more blood flow but just can't get more blood flow because of this blockage in the artery. Or if this becomes completely blocked off with a blood clot at the site of atherosclerosis, it can cause a heart attack, which is when there's all of a sudden no blood flow at all to all of this heart muscle beyond the blockage, and the heart muscle dies. And that's what a heart attack is. So this is coronary artery disease, and this is, again, what people are most often talking about when they talk about heart disease. But there are other common types of heart disease that you might have heard of, that you should be aware of as being distinct from coronary artery disease. And these include congestive heart failure, which is a weakening of the heart muscle or pump failure. Arrhythmias, which just means an abnormal heart rhythm, in which the heart rhythm can be too fast or too slow, or sometimes simply irregular. Or valvular heart disease, in which one of the valves of the heart becomes leaky or narrowed. Now, people with coronary arteries can also have these other types of heart disease, or somebody can just have one of these without coronary artery disease. Moving beyond the heart, though, there are other forms of cardiovascular disease that are important to be aware of. So stroke is a type of cardiovascular disease that is different from a heart attack in that in a stroke, the atherosclerosis is in the arteries that supply the brain as opposed to the arteries that supply the heart muscle. Stroke can also happen when there's a rupture of a blood vessel in the brain causing bleeding. So there are two different types of stroke. Another form of cardiovascular disease is peripheral arterial disease, where atherosclerosis, or those nasty cholesterol plaques, occur in arteries that supply the extremities, typically the legs. And this can happen this can result in pain in the legs with physical activity, sort of like angina, but in the legs. And finally, another important type of cardiovascular disease is aortic disease, of which the sort of most typical example would be an abdominal aortic aneurysm, which is when the aorta, which is the giant blood vessel that goes from the heart and branches into all the other arteries in the body, when that aorta gets stretched out. And that usually happens because the walls have been weakened by atherosclerosis or buildup of that cholesterol plaque. So patients who have atherosclerosis in one part of their body are at risk for having, or at increased risk for having atherosclerosis in other parts of their body. So what that means is that somebody who has had a heart attack, suggesting they have atherosclerosis in the coronary arteries, is at increased risk for also having stroke, peripheral arterial disease, or abdominal aortic aneurysm or other aortic disease, because once you have plaque one place, you're more likely to have it other places, and that's important to keep in mind. So what is the connection between cancer and heart disease? Why should you all care about this? Well, there's a bunch of reasons why cancer and heart disease are linked. First of all, cancer treatments can be toxic to the heart. Now, if we look at all cancer treatments, there's a lot of different types of cancer treatments that people get depending on the type of cancer that they have. And so not all of this is going to be applicable to a prostate cancer audience. But just to sort of give you an idea of the whole spectrum of what cardio-oncology is, some chemotherapies can cause weakening of the heart muscle, can cause atherosclerosis or narrowing of the arteries to the heart. They can cause severely increased blood pressure, or they can cause blood clots. Radiation, depending on where the radiation occurs, can cause narrowing of arteries, it can cause narrowing or leaking of heart valves, or it can cause stiffening of the heart muscle. And finally, hormonal therapy can cause increase in diabetes, abnormal cholesterol levels, obesity, as well as increased risk of heart attack and stroke. And so when we're talking about prostate cancer, for most people, the most relevant thing here is going to be the hormonal therapy for patients who receive androgen deprivation therapy, because there is some pretty good evidence that androgen deprivation therapy or hormonal therapy in prostate cancer does increase the risk of cardiovascular disease. It's important to keep in mind that although many patients may have radiation for their prostate cancer, radiation to the pelvis is not going to affect the heart. It's only if the heart is included in the radiation field that that's a problem. So again, for prostate cancer patients, the most significant effective cancer treatment is going to be the effects of hormonal therapy in those patients who receive it. Another important connection between cancer and heart disease is the fact that people with many types of cancer are at increased risk of heart disease even before treatment. So if you look at risk factors for cancer, and then you look at the risk factors for heart disease, you find that they overlap a lot of the time. So just speaking generally in terms of cancer in general, if you think about smoking is a risk factor for many different types of cancer. Smoking is also a risk factor for heart disease. So among a population of patients with cancer, you'd expect to find more smokers than in the general population, and therefore more patients with heart disease. The same is true for things like high blood pressure, diabetes, physical inactivity, and obesity, all of which are more common in many types of patients with patients with many different types of cancer. So you can see here on this slide here, this was a group of survivors of many different types of cancer, prostate, breast, colon, etc. But what they found was that compared to controls in the purple, the prostate cancer survivors were less likely to be a healthy weight here in the blue and more likely to be overweight and obese. In terms of physical activity, the controls were more likely to take part in any sort of physical activity, and so on, you can see for other risk factors. So cancer survivors and cancer patients tend to have higher rates of all of the cardiovascular risk factors compared to the general population, meaning that as a group, they're at higher risk for heart disease compared to the general population. If you look specifically at prostate cancer patients, this is a study that was done in Australia, where they looked at a whole bunch of patients with non-metastatic prostate cancer, and they referred all of the patients to a specialized clinic focused on heart and bone health. And what they found was that of these patients, almost 90% of them were overweight or obese, 60% had hypertension, 55% had high cholesterol, 25% had diabetes, another 25% actually had established cardiovascular disease, and over half the patients had a history of smoking. These are very high numbers compared to what you would expect in a random sample of men from walking down the street. What was also interesting about this sample is that in the orange, it shows patients who didn't actually know they had those risk factors until they were seen in this clinic. I'm going to talk a little bit more about that in the future, but often patients don't know that they have high cholesterol, they don't know that they have high blood pressure, or they don't know that they have diabetes. And if you don't know you have a problem, then you can't seek treatment for it. And treating these problems is one of the best ways of preventing heart disease down the road. This here is actually data that we collected in BC at the BC Cancer Agency, and this is patients referred to the cancer agency for androgen deprivation therapy or hormonal therapy for their prostate cancer. And we found again that high blood pressure was seen in 60% of those patients. And if you looked at age-matched controls from British Columbia, men of the same ages in a general population in British Columbia, only about 40% of patients had high blood pressure. So it was more common in the prostate cancer patients than in the men who lived next door to them. Diabetes was similar prevalence, but still occurred in almost 20% of patients. Over half of the patients had ever smoked, and half of the patients had high cholesterol. So again, we're seeing that these risk factors are very common in patients with not just all types of cancer, but now specifically in prostate cancer, they're very common. Now, again, one of the reasons why this might be is that things like high blood pressure, smoking, and high cholesterol actually have been shown to be associated with an increased risk of developing prostate cancer, of more aggressive prostate cancer, and an increased risk of recurrence of prostate cancer after it's treated. So again, it makes sense that they would cluster in a prostate cancer population. The other really important thing to know about this is that there's reason to believe that treating high blood pressure, treating high cholesterol, losing weight, quitting smoking, all of those things that increase your risk of bad prostate cancer outcomes, if you treat them, it may result in better prostate cancer outcomes in addition to improved heart health. And finally, I just want to finish up looking at the risk factors. So there's a risk factor calculator that we can use in cardiology where we're actually able to estimate an individual's 10-year risk of having cardiovascular events, of developing heart disease or stroke, basically. And so in our population of patients here in British Columbia with prostate cancer who were referred for hormonal therapy, we found that in fact, one quarter of those patients actually had established heart disease. Half of all of the patients were estimated to be at a greater than 20% risk of developing heart disease over the next 10 years, and 25% of patients were at an intermediate risk, estimated at a 10 to 20% chance of developing heart disease over the next 10 years. There was only 1% of patients in the entire population who had a less than 10% estimated risk of developing heart disease over the next 10 years. So I'm not trying to scare you, but you need to understand that patients with prostate cancer do seem to be at relatively high risk for developing heart disease. So it's important to take charge of things in advance and do everything you can to prevent that from happening. Finally, and this leads into this really nicely, the other reason why there's an important connection between cancer and heart disease is because the chances of surviving cancer are now better than ever. So it's now increasingly important to focus on other threats to the health of cancer patients and survivors. There was a time when patients uniformly died after a cancer diagnosis. But now we have great treatments. And so now we need to focus on what happens down the road. People are now living long enough to develop heart disease, and so we need to focus on that. Prostate cancer is something that is treated and then is almost sort of left behind while you focus on the rest of your life. And so it's important to make sure that the rest of your life is as good as can be, as high quality and as long as possible. So just to illustrate this shows cancer survival statistics in Canada, and this compares the early 90s to the late 2000s. And what you can see here is that for pretty much every type of cancer, the survival in Canada increased somewhere between 5 and 20% over that time period. And if you look specifically at prostate cancer, you can see here that while the survival was 86% in the early 90s, the most recent estimate is 95% 5-year survival after a prostate cancer diagnosis. So 95% of patients will not have died of prostate cancer after 5 years. Those 95% of patients need to be thinking about the rest of their health after that 5-year time course. Specifically looking at prostate cancer and heart disease, again, this is men aged 65 years and older. If you follow men for 15 years forward, only about 5% of patients will die of prostate cancer, but almost 20% of patients will die of heart disease. So heart disease is actually a much bigger threat to your long-term quality of life and longevity than is the prostate cancer in the vast majority of people. So it's really important, again, to take control of this and do everything you can to reduce that risk. So what are the risk factors for cardiovascular disease? Well, there are some risk factors that you just can't control. Your age is clearly linked to your risk of developing heart disease, and there's just nothing you can do about that. Your family history is what it is. If you have a history of family members with heart disease at a young age, you are at increased risk. And again, there's not much you can do about that. And finally, your ethnicity is associated with your risk of heart disease. And of course, your gender. And we're specifically speaking about prostate cancer survivors here, so we're going to assume that everybody's men. But there are lots of things that you can control. So important risk factors for heart disease that you can control, that we can intervene on, include smoking, high cholesterol, high blood pressure, physical inactivity, overweight and obesity, diet, and stress. We know that if you look worldwide, over 90% of heart attacks can be attributed to 9 modifiable risk factors. What that means was that if we could get every single person on the planet to quit smoking, to have perfect cholesterol, perfect blood pressure, cure their diabetes, get them to a normal weight, and so forth, we could actually get rid of over 90% of heart attacks that happen on planet Earth. So these are very modifiable. These are very, very important risk factors. We know that in patients who have no history of heart disease, that if we intervene on these, we can reduce the risk of heart attack and stroke in a single patient by over 80%. So there's lots of opportunity to improve outcomes, to reduce your risk of heart disease if you're proactive and willing to work to change your risk factor profile. But first, you have to go and see your doctor. And I'm sorry to tell you this, but men are notoriously bad at accessing preventive care. We know that in the United States, men over 50 years old are twice as likely as women to have undiagnosed diabetes because men just don't go to their doctors. They just don't get the blood tests done that are needed to diagnose this. Men are much less likely than women to follow other standard recommendations for heart disease risk management. They're about 1/4 as likely to have blood pressure checks according to guidelines, and about 1/2 as likely to have cholesterol checks according to guidelines. And so this is a major issue in terms of intervening and reducing heart disease risk. First, we need to get you guys to your doctors so that you can be checked out for these things. So what can you do to reduce your risk of heart disease? Well, first of all, stop smoking. Second of all, make sure that your doctor has checked your blood pressure, your cholesterol, and your blood sugar and started treatment if any of these are abnormal. You can increase your own physical activity level, and you can focus on eating a healthy diet. And I'll go through each of these individually. So stopping smoking. For those of you who are smokers in the audience, your family doctor is a great first resource. Your family doctor can provide you with many resources to help quit, including counseling, nicotine replacement therapy such as gum and patches, or non-nicotine replacement medications like Zyban. And so these are all great ways, these have all been proven to help people quit smoking. And so if you are even considering that maybe you should quit smoking, talking to your family doctor is a great first step. VGH also has a smoking cessation clinic that you can ask for a referral to, where you can meet with counselors who can provide counseling as well as provide prescriptions for medications or nicotine replacement therapy. And you should know that in BC, nicotine replacement therapy and non-nicotine replacement smoking cessation medications are covered. You can get them for free from the pharmacy. You just need to ask and go through the appropriate channels. And finally, there's a great website called quitnow.ca. This is what it looks like. It's pretty easy to remember. And on here, they have all sorts of resources to help you quit smoking, to give you advice if you're trying to get a loved one to quit smoking. There's even one box here specifically for men. So this is a great resource for those of you who are considering it. It's one of the single most important things you will ever do for your health. It will help to prevent your risk of heart disease. It will help to prevent cancer recurrence. It will improve your energy levels. It will reduce your risk of lung disease. There's just so many good things. I can't say enough about the importance of quitting smoking. Check your numbers. So there are basically 3 sets of numbers that go into your risk factor calculation. There's your blood pressure, your cholesterol, and your blood sugar. So a normal blood pressure, the textbook blood pressure, is 120/80. When you check it though, it should be consistently less than 140/90 in your doctor's office, or less than 135/85 if you're checking it not in a doctor's office. We acknowledge that we make you stressed out and we raise your blood pressure in clinics, so we give you a little wiggle room there. These though are the absolute cutoffs for the definition of hypertension or high blood pressure and where we should be considering to start treatment in patients. Lower is better though. If your blood pressure is 120/80, that's better for you than a blood pressure of 139/89. So if you're not already checking your blood pressure, you can always just stop at the pharmacy or the supermarket, stick your arm in the thing and see whether your blood pressure is high or low. If you're concerned that it's high, talk to your family doctor about it. Cholesterol is another really important number to have checked. It doesn't need to be checked every month, even every year, but everybody should have it checked at least once every couple of years to make sure that they don't require treatment. Your ideal cholesterol depends on your other risk factors. So a 25-year-old with perfect blood pressure and no other health problems, it's okay for them to have a little bit higher cholesterol than a 70-year-old diabetic who's had 4 heart attacks, right? So the ideal number is a little bit of a moving target, but there are really nice guidelines that your doctor will use in order to determine what your target cholesterol is and whether or not you should be treated with a cholesterol-lowering medication. You should know that LDL is the bad cholesterol, and that's the one that we treat aggressively with medication if it's too high. Well, HDL is the good or protective cholesterol. So your total cholesterol could actually be really high, but not that concerning if most of it was HDL. But when you get a cholesterol profile measured in the lab, your doctor will get all of those numbers back. Your cholesterol is roughly determined half and half by your diet and by your genetics. So you can improve your cholesterol to some extent by fixing your diet, but you can't fix your genes. And that's really what the medications are for. So the medications treat that part of your cholesterol that is just never going to come down with diet alone because you inherited crummy cholesterol from one of your parents. So that's why we often, even despite people's best efforts with changing their lifestyle and improving their diet, that's why often cholesterol pills are still required. That's also why you can't just put everybody on a pill and expect things will be perfect. You also need to put your work in with the diet to fix that other half of the high cholesterol. Your doctor, I kind of touched on this earlier, your doctor can calculate your 10-year risk of developing cardiovascular disease using your blood pressure, your cholesterol levels, your smoking status, your age, and your gender. And so they can come up with a number. You have a risk of 8% of developing heart disease over the next 10 years. You have a risk of 12% and you have a 27% risk. So based on that risk, you can identify patients who are higher risk and require more aggressive treatment. But you should keep in mind that this calculator doesn't take into account your family history. And if you have a family member who had a heart attack or a heart attack equivalent like a stroke at a young age, your risk is doubled. So if you know that you have a first-degree family member, so that would be a parent, a sibling, or a child, who had a heart attack or an equivalent to a heart attack like a stroke or needed bypass surgery or something like that, at less than age 55 in men or less than 65 in women, then your risk is doubled from what the risk calculator will calculate, and you should definitely be thinking about talking to your doctor about reducing your risk. And as I've kind of mentioned before, your target cholesterol is determined in part by your calculated risk. So somebody with a low calculated risk, we are willing to tolerate a higher cholesterol in. Somebody with a high calculated risk, that person with a 27% 10-year estimated risk, we're going to want to get on that, be super aggressive, and treat it to a low cholesterol level. So then just showing this slide again, now that I've kind of put things in perspective, this is our prostate cancer population again, where 25% of patients already had established heart disease and automatically fall into a high-risk category, people who should be aggressively treated. Another 50% of people have a more than 20% 10-year risk, they should be aggressively treated. And even the patients with a low Framingham risk score, not quite as aggressive, but often need treatment. It's only this 1% of patients who can get away with having a pretty high cholesterol, and we don't worry too much because their calculated risk is so low. The other targets to keep in mind, your fasting glucose and normal fasting glucose is less than 5.6. This is a really easy test that can just be added on to your cholesterol profile. When you get your cholesterol checked, you usually have to do it fasting, which means you go first thing in the morning before your first cup of coffee or breakfast. You can just add on a glucose there and do a really quick screen for diabetes. Body mass index is a number that we calculate from your height and your weight. A higher body mass index means more overweight or closer towards the overweight end of the spectrum. And normal is less than 25. So you can ask your family doctor to calculate your body mass index for you, knowing that a healthy body mass index would be less than 25. If you find it's higher than that, then you can talk to your family doctor about weight loss strategies. And finally, waist circumference should be less than 35 inches. And the reason we focus on waist circumference is because we know that fat that's in the belly is worse fat. It's more what we call metabolically active. It causes more inflammation in the body, and it's associated with increased risk of heart attack and stroke and all that other stuff. Compared to fat in the arms and the legs that seems to be less metabolically active, it just kind of sits there and doesn't cause as many problems for the rest of the body. We think this is one of the many reasons why men are at higher risk for heart disease than women, because men tend to put their fat in their bellies and women tend to put it in their legs. So waist circumference of less than 35 inches is really important because that's a marker of how much of that abdominal fat you have. So physical activity is something you can do on your own. You don't necessarily need to talk to your family doctor about it unless you've never exercised before in your life. You should probably let them know if you're planning to start doing something. But Canadian guidelines do recommend a minimum of 150 minutes per week of moderate to vigorous intensity physical activity. Now keep in mind that walking is moderate intensity physical activity. You don't need to join a gym, you don't need to buy a treadmill, you don't need to start doing the grouse grind on weekends. All you need to do is get 150 minutes a week of walking in, and that doesn't even need to be in big chunks. So you can go for a 10-minute walk at lunch, a 10-minute walk after dinner, and a 10-minute walk some other time in the day, and get 30 minutes in a day, and that's good enough. We like to focus on leisure time activity as opposed to the work you might do in your job. So if you're at work and you're on your feet all day long, we don't include that. For some reason, that does not seem to reduce your risk of heart disease as much as the exercise that you choose to do in your free time. Exercise reduces your risk of heart attack and stroke. It also helps to reduce your cholesterol, your blood pressure, and your blood sugar. Of course, we know it helps to reduce your weight as well as, so your BMI will come down, and it helps with abdominal obesity. So physical activity is an important risk factor on its own, but also affects a lot of the other risk factors. And it's also a great way to relieve stress, which we know is associated with increased risk of heart disease. Eating a healthy diet is also something that everybody should try and do to reduce their risk of heart disease. Now, there's a lot of things that go into a healthy diet, and there's a lot of different types of healthy diet out there. So patients, forgive me if you're on a kidney disease diet or a diabetic diet or something like that, you are already following all sorts of strict restrictions. But from a preventing atherosclerosis and cardiovascular disease perspective, it's important to cut down on saturated fats, trans fats, sugar, and salt. So you should try and incorporate more fruits, vegetables, cereals, dried peas and beans, and pasta into your diet, ideally whole grain. When possible, do things like choosing egg whites instead of egg yolks, choosing lean meats and fish instead of fatty meats, choosing skinless chicken instead of skin-on, fat-free or low-fat milk in your coffee instead of cream or whole milk, and olive oil instead of butter. Fried food is just not good for you in any way, shape, or form, so try and order things that are baked, boiled, roasted, or poached when you're out, or use those methods when you're cooking at home. And finally, alcohol is an important modifiable cardiovascular risk factor. We know that up to 2 drinks per day for men, 1 for women, is associated with a lower risk of heart disease. We don't recommend that people who don't drink start drinking to reduce their risk of heart disease. But if you do drink, we know that this amount is associated with a lower risk. So that's kind of what I have to say about lowering your own risk of heart disease, and I'm happy to answer questions in just a few minutes about specifics there. I just wanted to briefly touch on what is the VGH and UBC Cardio-Oncology Clinic, that's where I come to you from. We are a specialized clinic focused on the prevention and treatment of heart disease in cancer patients and cancer survivors. We're located on the 7th floor at VGH, so you guys are all pretty familiar of the Diamond Center at VGH, so you guys are all pretty familiar, I think, with the 6th floor. There's 1 floor up. We have 5 cardiologists who work there and 1 nurse practitioner. We're following over 700 patients with a variety of different cancers, and we strive to see urgent referrals within less than 2 weeks. Less urgent referrals will be seen in an appropriate time period. We see patients with all different types of cancer at all different phases of the continuum of cancer survivorship. Often we'll see patients who've had a decline in their heart function during cancer treatment, or who develop new cardiac symptoms during cancer treatment. The areas that are sort of most relevant to prostate cancer patients, we do a lot of risk stratification prior to treatment. So in patients who are planning to start hormonal therapy, for example, we'll often see them beforehand to assess their cardiovascular risk and look for ways to modify that cardiovascular risk. And we also do long-term follow-up for late effects of treatment. So in patients who have previously received therapies that could cause heart problems, we'll follow them in the long term and periodically do whatever testing is necessary. And we're also quite active in clinical research. Cardio-oncology is a really new and exciting field in cardiology. It's really only existed for the last 5 years or so. But these are kind of the things that we work on as a field. We try and identify patients who are at high risk for heart disease related to cancer treatment. We try and prevent damage to the heart and identify early damage before it's too late. We work towards finding effective treatments for patients who do have damage to their hearts, identifying the best strategies for long-term surveillance and risk management. And finally, we spend a lot of time just trying to keep up with all the rapid advances in cancer treatment, because oncology is changing so quickly. It's really exciting for cancer patients, for oncologists, and for us who also see the patients. So in conclusion, heart disease and its risk factors are common in prostate cancer survivors. As a result of advances in cancer treatment, heart disease may actually pose a greater threat to your ability to lead a long and healthy life than prostate cancer. And you can help to take control of your health by making changes in your lifestyle and talking to your doctor about your risk of heart disease. And I'm happy to take any questions.